By the time your doctor orders a bone scan, you may have already lost 30% of your bone density. And here's the part nobody tells you. It starts in your 30s, silently, without a single symptom. What you're about to learn could be the difference between standing tall at 70 or not. Let's talk about something that is quite literally holding you up right now: your bones. Not in the dry, textbook way you might have heard before. Not the drink your milk and take a calcium supplement advice you've been given your entire life. No, we're going to talk about what is actually happening inside your skeleton, why the medical system is decades behind in how it communicates bone health to women, and what you can do starting today. Not when you're 65, not when you get your first fractures. Today. Here's what strikes me most when I look at the research. 1 in 2 women over the age of 50 will break a bone because of osteoporosis. 1 in 2. That's not a rare condition. That's not bad luck. That's an epidemic hiding in plain sight. And yet most women won't hear a serious conversation about their bone health from their doctor until they're well past the point where prevention is easiest. Hip fractures in women, which are almost always osteoporosis related, carry a mortality rate within the first year that rivals some cancers. Let that sink in. We have entire awareness campaigns, walks, ribbons, and fundraisers for diseases that kill fewer women than bone fractures do. And still, this topic gets pushed to the bottom of the conversation. So today we are going to change that. We are going to go through 5 truths about bone health that most women are never told. Truths backed by research, explained in plain language, and built around what your body actually needs. Stay with me through all 5, because the last one is the one that almost nobody is talking about, and it may be the most important of all. Let's start with the most foundational misconception, because everything else builds on this. Most women believe osteoporosis is something that happens to older women, something you worry about in your 60s or 70s, something future you will deal with. And that belief, that completely understandable, widely reinforced belief, is costing women years of protection they didn't know they were giving up. Here is the real timeline. Your bones reach their peak density somewhere between the ages of 25 and 30. That's it. That's your ceiling. Everything your body builds during childhood, adolescence, and early adulthood, that is the bone bank account you are drawing from for the rest of your life. After that peak, a slow and natural process of bone resorption begins, gradually, quietly, without any pain or warning signal. By your mid-30s, your body is already losing slightly more bone than it's building. Most women don't feel a thing. Now here's where it gets important. Most people assume that the real bone loss crisis begins after menopause. And while menopause does accelerate things dramatically, the research tells us that significant bone loss actually begins 1 to 2 years before your last menstrual period, in the stage called perimenopause. That's the hormonal transition phase that can last anywhere from 4 to 10 years, and for most women, it begins somewhere in their mid-40s. So by the time you reach actual menopause and your doctor starts mentioning bone density, your body may have already been losing bone at an accelerated rate for several years. The reason comes down to estrogen. Estrogen is in many ways bone's most powerful protector. It works by suppressing the activity of cells called osteoclasts. Those are the cells responsible for breaking down old bone tissue. When estrogen levels are high and stable, your osteoclasts are kept in check, and your bone remodeling cycle stays balanced. But as estrogen begins its long, uneven decline during perimenopause, that suppression weakens. The osteoclasts become more active, the balance tips, and women can lose up to 20% of their total bone density in just the first 5 to 7 years after menopause. 20%. In less than a decade. And yet the standard medical recommendation in countries like the US, UK, Canada, and Australia is that women don't need a bone density scan until age 65, so unless they have specific risk factors. Think about that gap. You could be losing bone rapidly in your late 40s and early 50s, and the screening guidelines won't catch you until 65. That is not a personal failing of your doctor. That is a systemic gap that women deserve to know about. If you are in perimenopause or early menopause and bone health is not part of your healthcare conversation, you have every right to bring it up and ask for a DEXA scan. That's the gold standard bone density test. Early. So here's the first thing to carry forward. Bone health is not a postmenopausal issue. It is a lifelong issue, and the window for the most impactful prevention is earlier than almost anyone tells you. Now let's address the advice that has been handed to women for generations. Take your calcium, drink your milk, and while calcium absolutely matters, it is the primary mineral that makes up your bone tissue. The story is far more complicated than a supplement label suggests. Here is what the research actually shows. A major review published in the British Medical Journal found that calcium supplements alone do not significantly reduce fracture risk in most women. Not only that, but high-dose calcium supplementation, particularly from pills rather than food, has been associated with an increased risk of cardiovascular events, including heart attacks. The very supplement that millions of women are taking for their bones may, in high doses, be putting their hearts at risk. That does not mean calcium is the enemy. It means the source matters, and it means calcium cannot work alone. Your bones are not made of calcium in isolation. They are a complex living tissue that requires a whole team of nutrients working together. And the two most critical partners that calcium needs, the ones that are almost never mentioned in the same breath, are vitamin D3 and vitamin K2. Here's why this matters so much. Vitamin D3 is responsible for helping your gut absorb calcium from the food you eat. Without adequate D3, you can consume all the calcium in the world and your body simply won't take it in efficiently. But here's the part that almost nobody explains. Vitamin K2 is responsible for telling the calcium where to go once it's in your bloodstream. Without K2, that calcium does not reliably end up in your bones. It can deposit in your arteries, in soft tissues, in places you absolutely do not want calcification happening. K2 activates proteins that direct calcium into the bone matrix and away from the cardiovascular system. D3 and K2 are not optional extras. They are essential parts of the same biological process, and most calcium supplements don't contain either of them. Then there is magnesium, which plays its own critical and underappreciated role. Magnesium is required to activate vitamin D in your body. If your magnesium levels are low, and studies suggest that a significant portion of women in Western countries are running low on magnesium, then your vitamin D, even if you're supplementing, may not be functioning at full capacity. Magnesium also directly contributes to bone crystal formation. It's not a side character in this story. It's a lead. So what should you actually eat? The best sources of food-based calcium include full-fat dairy products, with fermented options like yogurt and kefir being particularly beneficial because the fermentation process improves calcium absorption and also provides gut-supporting bacteria, which, as we'll discuss later, has its own connection to bone health. Leafy green vegetables are excellent sources, with an important nuance. Kale, bok choy, and broccoli are much better absorbed than spinach because spinach contains high levels of oxalates that bind to calcium and block its absorption. Canned sardines and salmon eaten with the bones are remarkably rich sources of highly bioavailable calcium. And if you use fortified plant milks, check the label carefully. You want D3 and ideally K2 added, not just calcium carbonate alone. The practical goal, according to most national health guidelines, is around 1,000 to 1,200 milligrams of calcium per day from food sources. If you genuinely cannot meet that through diet, a low to moderate dose supplement taken with food and alongside D3 and K2 is a reasonable conversation to have with your healthcare provider. But the era of treating a single supplement as a complete bone health strategy needs to end. This truth tends to surprise even the most health-conscious women. If you are someone who walks regularly, does yoga, swims, or cycles, First of all, those activities are genuinely wonderful for your cardiovascular health, your mental well-being, your flexibility, and your longevity. Please don't stop. But here is something the research is very clear about. They are doing relatively little for your bone density, and that gap matters enormously. Bone is a responsive, adaptive tissue. It follows a principle that scientists call Wolff's Law. The idea that bone will strengthen and remodel itself in response to the mechanical stresses placed upon it. When you apply force to bone, through impact, through resistance, through load-bearing activity, the cells that build new bone, called osteoblasts, receive a signal to get to work. The bone responds by becoming denser, stronger, more resilient. But when those forces are absent, when movement is gentle and repetitive without challenge, that stimulus simply is not sufficient to trigger meaningful bone remodeling. Swimming, despite being excellent for joints and cardiovascular fitness, involves no gravitational load on the skeleton. Cycling is similar. You are seated, supported, and while your legs are working hard, the skeleton is not bearing the same kind of mechanical challenge it needs to rebuild bone. Even regular walking, while beneficial, tends to plateau fairly quickly as a bone stimulus because the body adapts to familiar loads. What actually builds bone? The evidence points most strongly to two categories of activity. The first is resistance training, lifting weights, using resistance bands, performing bodyweight exercises that progressively challenge your muscles and, through them, your skeleton. The second is high-impact loading, activities like jumping, dancing, tennis, hiking on uneven terrain, and even skipping. These create the kind of mechanical signals that most powerfully stimulate bone formation. A landmark clinical trial called the Lift More study, conducted in Australia, looks specifically at what happens when postmenopausal women with low bone density engage in high-intensity resistance training. We're talking heavy deadlifts, overhead presses, and squats performed under supervision. The results were striking. Women in the high-intensity group showed significant improvements in bone density at the hip and spine, the two most critical fracture sites, compared to those doing low-intensity exercise. And crucially, the exercise was performed safely, with very few adverse events, even in women who already had osteoporosis. The practical takeaway is this: aim for at least 2 resistance training sessions per week, targeting the major muscle groups connected to the spine, hips, and wrists, because those are where fractures are most common and most devastating. Include compound movements that load the whole skeleton: squats, deadlifts, rows, overhead pressing. Add some impact where your joints allow it. Even jumping in place for a few minutes a day has shown measurable benefit in bone density studies. And if you are already in your 50s, 60s, or 70s and thinking it's too late, the research says otherwise. Women well into their 70s show measurable bone density improvements from resistance training. The body retains this capacity far longer than we've been led to believe. Here is where the conversation takes a turn that many women find genuinely surprising, even unsettling, because some of the things quietly depleting your bones are things you may be doing every day, often on medical advice. Let's start with medications. Proton pump inhibitors, the class of drugs commonly sold under brand names for acid reflux and heartburn, are among the most widely prescribed medications in the world, and women are prescribed them at high rates. What most people are never told is that long-term use of PP significantly reduces the body's ability to absorb calcium, because stomach acid plays a role in breaking calcium down into an absorbable form. If you have been on a PPI for months or years, your calcium absorption has likely been compromised, and your bone density may have suffered as a result. This does not mean you should stop your medication without medical guidance. But it does mean you should have a conversation with your doctor about whether you truly need to continue and whether your bone health is being monitored. Corticosteroids, used for conditions ranging from asthma and rheumatoid arthritis to skin conditions and allergies, are one of the leading causes of what's called secondary osteoporosis. They suppress bone formation directly, reduce calcium absorption from the gut, and increase calcium loss through the kidneys. Even inhaled corticosteroids used for asthma at high doses over long periods carry bone risks that are rarely communicated to patients. If you are on long-term steroid therapy of any kind, bone protection should be an active part of your medical management plan. There is also emerging evidence around certain antidepressants, specifically SSRIs, and a modest but real effect on bone density, possibly through serotonin receptors that exist on bone cells. This is not a reason to avoid antidepressants, which are life-changing medications for many women, but it is a reason to ensure your bone health is part of the broader conversation when you are managing long-term mental health treatment. Beyond medications, chronic stress is one of the most overlooked bone threats. When you are under prolonged stress, your body produces elevated levels of cortisol, the primary stress hormone. Cortisol directly suppresses osteoblast activity, meaning your bone-building cells are working at reduced capacity. It also reduces estrogen, further tipping the hormonal balance away from bone protection. The women who are running on adrenaline and cortisol for months and years at a time are not just burning out mentally, they are literally eroding their skeletal resilience. Smoking has a direct toxic effect on osteoblast cells and also interferes with estrogen metabolism, compounding the hormonal impact on bone. Alcohol, when consumed regularly above 2 drinks per day, impairs bone formation and significantly increases fall risk, which is its own separate fracture danger. And excessive caffeine, while not the crisis it is sometimes portrayed as, does cause a small increase in calcium excretion through the urine, which over years of very high intake can accumulate into a meaningful deficit. This is the truth that the mainstream conversation has been slowest to catch up with, and it may be the most fascinating. Your gut and your bones are in constant conversation through mechanisms that researchers are only beginning to fully understand, and the health of your gut microbiome has a direct and measurable influence on how well your body absorbs bone-building nutrients and how your bone metabolism functions. The gut microbiome, the trillions of bacteria, fungi, and other microorganisms living in your digestive tract, influences bone health through several pathways. First, and most directly, the health of your gut lining determines how efficiently you absorb calcium, magnesium, vitamin D, vitamin K2, and other bone-critical nutrients. A gut that is inflamed, damaged, or populated by an imbalanced community of bacteria will not absorb these nutrients efficiently, no matter how much of them you consume. Women with conditions like irritable bowel syndrome, inflammatory bowel disease, celiac disease, or even a history of frequent antibiotic use may have compromised absorption that is silently undermining their bone health. Second, the gut microbiome produces short-chain fatty acids through the fermentation of dietary fiber, and these compounds have been shown to directly influence osteoblast and osteoclast activity, promoting bone formation and reducing bone resorption. A microbiome that is diverse, fiber-fed, and rich in beneficial bacterial strains produces more of these protective compounds. A microbiome depleted by ultra-processed food, low fiber intake, chronic stress, and frequent antibiotic exposure produces far fewer. Third, the gut-brain-bone axis involves the immune system in ways that are still being mapped by researchers. Gut inflammation promotes systemic inflammation, and chronic low-grade inflammation is increasingly recognized as a driver of bone loss. Because inflammatory signaling molecules directly activate osteoclasts, accelerating the breakdown of bone tissue. What does this mean practically? It means that supporting your gut health is not separate from supporting your bone health. It is part of the same strategy. Eat a diverse range of plant foods to feed a diverse microbiome. Include fermented foods like yogurt, kefir, kimchi, sauerkraut, and miso, which introduce beneficial bacterial strains directly. Minimize ultra-processed foods, which disrupt microbial balance and promote the kind of gut inflammation that ripples outward into your entire body, including your skeleton. If you have ongoing gut symptoms, take them seriously and work with a healthcare provider. Because what is happening in your gut is not staying in your gut. This final truth is perhaps the most emotionally charged, and it requires the most nuance because it touches on decisions that are deeply personal and medically complex. But it is a conversation that too many women are being denied, and that denial is affecting their bones. For decades following a large study called the Women's Health Initiative, published in 2002, hormone replacement therapy, or HRT, was treated with widespread fear. The study suggested increased risks of breast cancer, heart disease, and stroke, and the medical community largely pulled back from prescribing it. Millions of women were either taken off HRT or never offered it in the first place. And while those concerns were real and the science was being processed in real time, the story has since been significantly revised. Subsequent analysis of that original data revealed that the risks were substantially dependent on the type of hormones used, the age at which therapy was started, how long it had been since menopause, and the individual woman's health profile. For women who begin hormone therapy within 10 years of their last menstrual period, what researchers call the window of opportunity, the evidence now suggests that the benefits for bone health are significant, and the risk profile is far more favorable than the 2002 headlines implied. Estrogen therapy is, in fact, one of the most effective interventions we have for preventing postmenopausal bone loss. It works directly at the level of the osteoclast suppression we discussed earlier, essentially slowing down the biological process that accelerates bone loss when estrogen declines. This does not mean hormone therapy is right for every woman. There are individual risk factors, certain types of breast cancer history, blood clotting disorders, and others seen that make HRT unsuitable or require careful consideration. But what it does mean is that every woman in perimenopause and early menopause deserves to have a real, evidence-based conversation with her healthcare provider about whether HRT is appropriate for her, says she, including its implications for bone health, rather than having that option quietly withheld out of outdated fear. If your doctor has not brought this up, bring it up yourself. Ask specifically about your bone density, your fracture risk, and whether hormone therapy is something worth exploring in your particular case. You are entitled to that conversation. You are entitled to make an informed decision. And you are entitled to know that the science has moved on considerably from where it stood 2 decades ago. So let's bring this all together, because information without action is just anxiety. Here is what the evidence actually supports, distilled into the most important things you can do, regardless of your age, your current bone density, or where you are in your hormonal journey. Eat for your bones, not with a single supplement, but with a full nutritional strategy that includes food-based calcium, paired with D3, K2, and magnesium. Prioritize fermented dairy, bone-in fish, leafy greens, and a wide variety of plant foods that also support your gut microbiome. Move in ways that challenge your skeleton, not just for cardiovascular fitness, but with progressive resistance training and some form of impact activity at least twice a week. Audit your medications and your lifestyle honestly. Have a conversation with your doctor about any long-term prescriptions that carry bone risks, and take stress, sleep, smoking, and alcohol seriously as bone health factors, not just general health factors. Support your gut, because your gut is supporting your bones in ways that go far deeper than most people realize. An advocate for yourself in the healthcare system. Ask for a DEXA scan if you're in perimenopause and nobody has mentioned one. Ask about your fracture risk score, and ask about hormone therapy as one tool among many that deserves a fair hearing. Your bones have been working for you every single minute of your life. They hold you upright, protect your organs, and give you the literal structural foundation to exist in the world. They deserve the same level of attention, understanding, and care that you give to every other aspect of your health. The information exists, the research is there, and now, so are you.